Sneha around? Can she flash the first slide, please? Yeah, good evening, everyone, and welcome to, again, another Cracking Wednesday. And today we have a topic regarding which the questions have been asked in multiple sessions in the previous various other activities of POCM. The topic as flashed over here is Opsoclonus Myoclonus Ataxia syndrome, challenges and solutions. And we have the authority on this topic to discuss it with us today. The moderator was supposed to be Dr. Lokesh, but he has got caught up somewhere. He'll possibly join us in between. I'll request Dr. Naveen to please introduce our speaker, and then we take it on from there. Naveen, sir, please.
Thank you, Vishal. Can we have the slide, please?
The next one, please.
Yeah. So we are indeed delighted to welcome Dr. Mark Gorman, who is the Director of Pediatric MS and Related Disorders and the Neuroimmunology Program at the Harvard Medical School, Boston. He's a world-renowned figure in pediatric neuroimmunology, and he is also the founding director of Pediatric MS and Neuroimmunology Programs at the Boston Children's Hospital, and this has been running since 2008. He is also the member of International OMA Study Group, and he's published more than 100 articles and a lot of interesting articles on OMAs and other neuroimmunological disorders. So without much delay, I think we just are very eager to hear from him on this topic. Dr. Gorman, please.
Great, thank you so much, Naveen and Vishal, for the kind invitation. I was saying that I was in Mumbai for the 2018 International Child Neurology meeting and loved it, and wish we could be in person, but this is also, as I was also saying, I'm so impressed at the number of sessions that you have for education. So let me share my screen here, and then can you see my introductory slide here?
Yes, yes.
Okay, great. So today I'll talk about Opsoclonus Myoclonus Ataxia syndrome and some challenges and potential solutions. Just for some disclosures here, the most relevant is that I did receive funding from Pfizer for an OMAS project, although I won't discuss that project today. And then unfortunately, none of the treatments for OMAS are FDA or EMA or any drug authority approved. So I always want to say that. And some of the content, especially on some of the very challenging but very appropriate questions that Naveen posed to me, is more based on my experience than necessarily published literature. And I'll try to indicate that when that comes up. By the end of the talk, for objectives, I'll hope that will know the high risk of relapse in OMAS, develop an acute approach to managing them, and to consider some preventive treatment strategies. Secondly, for patients who are diagnosed with OMAS but not responding to initial immunotherapy, to reconsider differential diagnosis, workup, and then treatment strategy. And last, to know the unfortunately high rate of cognitive sequelae in patients with chronic OMAS, its anatomic basis, and then potential preventive treatments. So given that the majority of the audience is child neurologists, I won't go too much into the background of OMAS, but did want to give at least a brief overview so that we're all starting from the same page. OMAS is a clinical diagnosis. Even though there's been an intensive search for biomarkers for OMAS, there currently still is no established biomarker. So what we use are diagnostic criteria. These were developed and published in 2005 by a group of experts. And in those criteria, OMAS is defined as an autoimmune neurological disorder targeting the cerebellum, and it's characterized by at least 3 of the following 4 features. Number 1, Opsoclonus. Number 2, Myoclonus or ataxia. These are grouped together because oftentimes it's difficult to distinguish which movement is exactly myoclonus and which movement is exactly ataxia. Thirdly, and oftentimes the most distressing, behavioral change and/or sleep disturbance, which can range from mild irritability up to frank rage attacks. And then fourthly, neuroblastoma. So if you see a patient and they have 3 of those 4 features, you can be confident in making a diagnosis. OMAS is a rare disease. In one study from the UK, the incidence was estimated at 0.18 cases per million, or about 1 per 5 million children per year. That said, it certainly does come up in child neurology practice and is important to consider in patients, particularly patients presenting with ataxia. In terms of some demographics, the median age of onset is 18 to 22 months, although it does occur in older children as well, and also occurs in adults. It's slightly more common in females, around 55 to 60% of cohorts are females. It affects all racial and ethnic groups, and it occurs worldwide. Some challenges in making a diagnosis of OMAS, although I outlined the diagnostic criteria, all of those features may not be present at onset. So for example, a patient may present initially just with ataxia and only develop the other signs over time. And sometimes they may lack a specific feature altogether. The Opsoclonus can be fleeting and missed on exam. One little pearl that I always like to say is that if I'm seeing a patient where I'm considering the diagnosis of OMAS, I tell the parents, while I'm taking the history, I won't look you in the eye at all, and I'm not trying to be rude, but I'm going to stare at the child's eyes for the entire time that I'm taking the history. Because the Opsoclonus can literally be a split second, and if it's subtle, and you can miss it otherwise. I also take into account if the family reports any abnormal eye movements, but I don't see them on exam. I still put a lot of stock in what the parents have observed, because again, it can be very intermittent. As I mentioned, there's no diagnostic test yet. Hopefully we will have one in the coming years. And so OMAS is still a clinical diagnosis, which is one of the challenges, but also in some ways kind of fun old school neurology. As I mentioned, neuroblastoma can be a feature of OMAS. In most pediatric cohorts, approximately 50% of patients are found to have a neuroblastoma. This is a figure taken from a very nice review article published a few years ago, outlining the mechanistic framework for how a neuroblastoma can lead to OMAS. And this is kind of the classic paraneoplastic paradigm, where you have the neuroblastoma, which presents an antigen. We still don't know what the target antigen is. Nonetheless, we think that antigen gets presented to the immune system. There's been a lot of focus on the B cell arm of the immune system in OMAS. So this antigen presentation leads to activated B cells. Activated B cells ultimately become plasma cells, which produce antibodies that cross-react with the neuroblastoma, but unfortunately also injure the cerebellum. And there's been decades-long search to try to find the particular autoantibody in OMAS, but it still has not been found. And although B cells have gotten the most attention in OMAS, T cells also likely play a role. One question that often comes up is, okay, we know that 50% of patients with pediatric onset OMAS have a neuroblastoma. What's the best way to go about looking for that? This is my approach and is based on literature which has shown the relative sensitivities of the different methods. I typically start with a chest X-ray and abdominal and pelvic ultrasound because they're very easy to get and non-invasive. and sometimes we'll pick up the tumor, and so you can know relatively quickly, and it may also guide your subsequent imaging. If we see a mass on those, I'll consult oncology for further guidance on the imaging and staging. If it's negative, I'll go right to a neck through pelvis MRI. The reason for going right to MRI and skipping, for example, MIBG scans is that MRI is more sensitive than MIBG scans. In addition, tests like urine catecholamines are actually very insensitive in the context of OMAS. So you can certainly check them, but if they're normal, it doesn't rule out a neuroblastoma by any means. I have had the experience, and there's one or two case reports published where we have done the extensive imaging at onset and it's negative, but then when you look again in about 6 months, now you see the tumor. To be honest, many times if you look in then retrospect at the original MRI, you can see something there. And this points out the fact that many of these tumors are small, kind of going along with the paraneoplastic paradigm, where the immune attack keeps the tumors small. There is no absolute 100% gold standard of treatment for OMAS. There actually has been one randomized clinical trial that was published that was run by the Children's Oncology Group that was published a few years ago. It took a very long time to recruit for that trial. And so by the time it was published, some of the agents that were used are actually no longer typically used, at least up front, which was in that study, all patients got steroids and cyclophosphamide, and then were randomized to IVIG or no IVIG. So this is my best synthesis of the evidence, and also extrapolating from my experience and then the publications in other types of neuroimmune diseases. So this is my approach, but again, there's no absolute 100% gold standard. If you find a tumor, you want to remove it, ideally with complete resection, to try to remove that antigenic stimulus. Occasionally, although it's quite rare, sometimes patients will require tumor-directed chemotherapy that the oncologists would manage. If the tumor is completely resected, or if they don't have a tumor, then I'll proceed with induction, trying to induce a remission with multi-agent immunotherapy, which includes 3 different prongs. So the first is steroids. I typically use dexamethasone at this dosing, 20 milligrams per meter squared per day for 3 days monthly. Another option would be prednisolone, starting at 2 milligrams per kilogram per day. My goal is to try to be off of steroids by 12 months, which we can't always accomplish, but that's my kind of goalpost there. You may know that ACTH is also used in the treatment of OMAS, and there's a number of publications on that. And there's some providers in the field who also have a lot of experience who feel that ACTH is more effective than steroids. I think the jury's still out, and I haven't seen clear evidence to support ACTH over steroids, but just to know that some people feel that it is more effective. So steroids is the first category of treatment. The second is IVIG. And then the third is rituximab, and we'll go through rituximab, the data to support its use in a little bit more detail. My dosing regimen has changed over the years, back and forth. Currently, this is the dosing that I use, which is 375 milligrams per meter squared per week for 4 weeks. I give all 3 upfront pretty much to every single patient that I see, knowing that, as we'll see, there's a high rate of relapse and adverse long-term outcomes. So I want to do everything that I can to try to prevent relapse and preserve long-term outcome. I then start to monitor for B-cell repopulation. I start early at 3 months after rituximab and continue to check them monthly. And then, depending on the circumstances, may consider a second course of rituximab. Along the way, and also in the more chronic phases, since many of these patients will still have residual symptoms, supportive care is very important. Sleep disturbance is very common, and agents like melatonin, clonidine, gabapentin, and trazodone can be helpful. For the irritability and rage attacks, clonidine and risperidone can be helpful. For the developmental delays, physical therapy, occupational therapy, speech therapy. And then for their cognitive delays, we perform neuropsychological testing, usually around school age in all of our patients, and try to support them with school plans and educational accommodations. So that's kind of a quick overview of some of the main aspects of OMS. Naveen posted me some very challenging but very appropriate and critical questions in the field. And so for the rest of the three sections, I'll go through those. So the first is on relapses. And it sounds maybe simple, but first we have to try to define what is a relapse. As was mentioned earlier, I also see patients with multiple sclerosis. And as you know, the majority of patients have relapsing remitting disease. But first, before they even got to that, the field had to get together and create a definition of a clinical relapse. Historically, in the field of OMAS, there really has not been a consistent definition. We have, based on one prior publication by Dr. Pranzatelli, who was a pioneer in the field of OMAS, and then based on our subsequent experience in a recent study that we published with colleagues from Oxford and Switzerland, we defined a relapse as this: worsening of OMAS symptoms lasting at least 72 hours, following a period of stability or improvement for at least 30 days. We chose 72 hours as opposed to 24 hours. That's used in multiple sclerosis, for example, because we've seen that there can be more variability in symptoms and fluctuations in symptoms with OMAS on a shorter time scale that don't seem to then proceed into a full-blown relapse. So we chose 72 hours rather than 24 hours. There's not been extensive validation of this definition, but as I'll show later, in our study, the number of relapses as defined this way did correlate with worse outcomes. So there is some real world validation for that definition. Sometimes it can be tricky as you're seeing a patient over time, and the parents may be reporting new symptoms or maybe not reporting new symptoms, and you're seeing them in clinic, and you're trying to gauge, are they same, better, or worse? There are a few different scales that can be used that can be helpful to measure and track symptoms over time. These are three different scales. One was developed by Dr. Pranzatelli, which is called the Opsoclonus Myoclonus Evaluation Scale of Motor Performance. A second is the Mitchell and Pike OMS Severity Scale. And then the third is not OMAS specific. It's used more broadly for ataxia and is called the Scale for the Assessment and Rating of Ataxia. I personally use the Mitchell and Pike scale. It's very easy to use. It does have some limitations, but it's very easy to use in clinical practice. And then the SARA scale I use once the patients are 4 years old and above, because it's a bit more detailed, and it's been validated down to 4 years old, but not below that. A big question that comes up, of course, and one that parents will ask when you make a diagnosis is, what are the chances of relapse? Looking through the literature, and then in our experience from this relatively large cohort that we published, approximately 70% of patients will have at least one relapse, with the remaining staying monophasic. In the same study that we published, of 71 patients who had sufficiently detailed data, the median number of relapses per patient was 2. and that was over about 68 months of follow-up. So relapses do occur, although in most patients aren't very frequent, although we see here in the range that there is a significant range, and some patients unfortunately do have a lot of relapses. In terms of the timing of relapses, this is a very understudied area. I'm not aware really of any publications that have looked at this closely, but in my experience, and similar to other neuroimmune diseases, the risk of relapses tends to be highest, closest to the onset of OMAS, and then gradually declines over time, possibly quote unquote burning out, at around age 5 or 6, although there are certainly some patients who relapse even after that. Similarly, the severity of relapses has not been well studied, but in my experience, the severity of relapses tends to be less severe than the original onset, thankfully. And that's similar to what's been published, for example, for anti-NMDA receptor encephalitis. From a practical standpoint, then, you do have to be attuned to potentially more subtle worsening than what was seen with the original onset, when it tends to be quite severe. So if you're following a patient with OMAS and you've determined that they are indeed having a relapse, what do you do? The first is to assess for any triggers. One very common trigger for relapse is infections. Typically, that is a non-specific viral infection. There's nothing you can particularly do. Occasionally, it is due to a bacterial infection, and treating the bacterial infection may be sufficient. The second is as you're tapering immunotherapy, and that's also a high-risk period for relapses. How best to treat relapses acutely is not well defined, but dexamethasone, similar to how we use it as kind of an arm of the triple therapy from the onset, you can use that more acutely for relapses, and oftentimes is effective. And then in addition to treating the acute relapse, of course, you want to take a step back and say, what can I do, if anything, to try to prevent future relapses? And what is the patient's current baseline treatment? I had outlined my approach to treatment, but of course, potentially a patient may not have received rituximab yet. And if they haven't yet received rituximab and they're now experiencing a relapse, I would very strongly consider adding it in at this dosing. If the patient has indeed already received rituximab, I'll want to check the B cell number during the relapse, and then look to see if the B cells have repopulated yet, and if so, then consider a repeat course. If the B cells are still 0, then the likely conclusion is that rituximab has failed, and you'd want to consider treatments with alternative mechanisms of action. Although we use rituximab, and I do think fairly strongly that it does help to prevent relapses of OMAS, there aren't actually many studies that have been published to prove that. We hope that changes in the future. And then a second issue is that, as I mentioned, we oftentimes combine rituximab with other treatments. So as we're trying to look at what is the effect of rituximab, it can be difficult to isolate that specific effect. One early study which promoted the use of rituximab was done by Mike Pranzatelli, in which he looked at 12 patients using rituximab in addition to ACTH and IVIG, started relatively early in the course. And when they looked at those patients at 12 months, it appeared that they had less relapses compared to historical cohorts. I'll shift gears a little bit, although there's certainly a big overlap between patients who relapse and patients who don't respond to treatment. Similar to relapses, there's really no clear definition for a non-responder, but certainly there are some patients who don't seem to improve sufficiently with their whatever initial treatment you choose to use. And these oftentimes will blend together with patients who are having frank relapses. So you'll diagnose the patient, start them on treatment, and then follow them. They're really not maybe making as much progress as you would like to see. And then sure enough, they actually have like a frank worsening of symptoms. So the relapsers and the non-responders, I think the Venn diagram overlaps quite significantly. So, not just for OMAS, but, for any neurological disorder, I always then say, okay, maybe I'm wrong. Maybe I made the wrong diagnosis. It's not the wrong treatment, it's the wrong diagnosis. So always a good time to take a step back and say, could this be an alternative diagnosis? This isn't published, but just sharing my experience with some disorders that I have seen over the past decade or so, patients who were referred to me for OMAS or a question of OMAS, but who ended up having a different diagnosis. So one category are genetic eye disorders, which I knew very little about until I saw a couple of patients. I am especially suspicious of this category if the symptoms start at a very young age. So especially if they're starting at less than 3 months old, that's a big red flag for me. And I want to get a very detailed neuro-ophthalmologic assessment and then strongly consider genetic testing. Second category are leukodystrophies. And I've seen patients with metachromatic leukodystrophy and Tay-Sachs disease, both of whom presented with ataxia, had some abnormal eye movements, were relatively early in their course, so had not yet progressed to a more severe state. And the question of OMAS was raised. And then lastly, glucose transporter deficiency due to mutations in GLUT1 can also mimic Opsoclonus myoclonus, because those patients oftentimes will have abnormal eye movements and ataxia. And that will be diagnosed initially with a lumbar puncture and then confirmed with genetic testing. Most of the time, even after you've gone through this exercise of reassessing the differential diagnosis, you're still going to go back and say it is OMAS. It's just not responding as well as I would like. So then the next question to ask is, have you given the treatment enough time to work? With OMAS, it's generally quite severe at onset. And then even with aggressive multi-agent therapy, the improvement is relatively slow over weeks to months. So think more like what you see with anti-NMDA receptor encephalitis, not what you see with something like ADEM. So sometimes you just have to be patient and give your initial treatment some more time. Exactly when to say, okay, I've given it enough time, I need to shift gears is not clear, but probably on the order of weeks to months. Another question to ask, and this is more relevant sort of later on in the disease course, but to say, okay, seeing these symptoms, they don't seem to be responding to immunotherapy. Is this true active disease due to active neuroinflammation, or is this simply reflect, unfortunately, sequelae from previous relapses and previous brain injury? So in looking at that, some practical things you can do. One, as I mentioned, you say, so how far along into the disease are they? The further out they are from disease onset, the more likely it is that you might be dealing with sequelae rather than active disease. Although I don't typically do like routine surveillance brain MRIs because they don't necessarily change management. Although some patients can have cerebellar atrophy, not everybody does. Nonetheless, if I'm in a situation where I'm trying to decide, is this active disease or is it sequelae? If I get aggressive again with treatment, how much yield am I going to get from that? I'll consider doing a brain MRI to see if there's any cerebellar atrophy. The idea being that if you've already if you're already seeing atrophy, you may not get that much from aggressive treatment. And then lastly, although I do a lumbar puncture at baseline in all patients. I don't necessarily do serial surveillance lumbar punctures, but again, if I'm debating whether or not to escalate treatment, I'll consider repeating a lumbar puncture, looking for signs of active inflammation, which can include elevated white blood cells, elevated neopterin, and or an increase in B cell percentage on flow cytometry. So this was really the central part of Dr. Pranzatelli's work in OMAS, where he showed that there was an increased percentage of B cells in the CSF in most patients with active OMAS. So that's another test that you can consider, although in my opinion, the exact role that this plays still is yet to be defined. So let's say you see the patient, you're following them, treating them, you've come to the conclusion that, you know what, whatever I'm doing right now is not sufficient. I need to change courses. What can I do? So these are some options. Again, this is just kind of options. There's no absolute gold standard, no trials that have assessed this. But one thing you can consider is switching your form of steroids. So if they're currently on dexamethasone or prednisolone, you can consider switching to ACTH. If they're on ACTH, you could consider the opposite. Most patients I maintain on IVIG every 4 weeks. Sometimes you'll see kind of that 3rd to 4th week where the symptoms will get worse. And so if that's the pattern, then I'll consider changing the frequency to every 3 weeks. If they haven't gotten rituximab, or if they've gotten rituximab and have now repopulated their B cells, I'll consider adding that in. One thing that has emerged and that I have certainly seen in a few of my own patients is that although rituximab is a generally well-tolerated immunosuppressant medication, there is a risk of hypogammaglobulinemia. I always discuss this with the parents up front. And there have been a couple of publications, including this nice publication from the Barcelona group that showed that younger age repeated courses in what they termed the concentrated regimen, which is 750 milligrams per meter squared times 2 doses. And then curiously, a neuroimmunologic diagnosis compared to a rheumatologic diagnosis, all of these increase the risk of hypogammaglobulinemia. So I do monitor immunoglobulin levels, and if I see that the patient is developing hypogam, I might consider something other than rituximab. And so originally, when I first started treating patients with OMAS with rituximab, I used the traditional 375 per dose times 4 doses. Then, similar to what's done in rheumatology and in adult neuroimmunology, I switched to the 2-dose regimen. And now with this publication, I've gone back to the 375 because potentially it might have less of a risk of hypogam. If you've already tried rituximab and let's say determined that it failed, another option is to add cyclophosphamide at this dosing. This was used as a backbone treatment in that Children's Oncology Group trial that I mentioned that was published in 2018. Beyond that, there's very, very little publications and relatively little experience, but mycophenolate and azathioprine have also been used. And then last section, and then we'll save time for questions, which I see are coming in, which is great. I'll talk a little bit about patients who are, in more chronic phase, let's say 10, 15, 20 years old. What does that look like, and how do we follow those patients? So unfortunately, if you look at historical case series, at least 80% of patients with OMAS will have persistent neurological deficits. Although in the acute phase, it's the Opsoclonus and the florid ataxia that's oftentimes the most striking. those problems tend to get better, oftentimes completely resolve over time. And so those are actually not the long-term issues. So patients, the Opsoclonus typically goes away completely. The frank ataxia tends to go away, although you can find incoordination with more challenging tasks. And now that I've started to do that SARA scale that I mentioned earlier, I'm picking up much more subtle deficits in my chronic patients. But nonetheless, it's really the cognition and behavior and psychiatric symptoms that impair their outcome. This can include frank intellectual disability with historically IQs in the range between 50 and 80. Even in patients with an average IQ, they can have more subtle problems with attention. Some patients can even develop autistic-like features, may even meet criteria for autism. And then speech difficulties are quite common. This, as I mentioned in one of the objectives, why would a cerebellar disorder cause such significant problems with cognition, mood, behavior? Isn't the cerebellum, a motor control center? And certainly that was the historical view, but over the past couple decades, the concept of the cerebellum playing a role in cognition and behavior has been highlighted and has been termed by my colleague, one of my adult neurology colleagues at Massachusetts General Hospital, Jeremy Schmaman, uses the term cerebellar cognitive affective syndrome. And this kind of highlights the role that the cerebellum plays, particularly in these domains of expressive language, visual spatial skills, attention, and mood regulation. And it turns out this is not specific to OMAS, as the cerebellum has been implicated in other conditions as well with prominent cognitive and psychiatric features, including things like autism, but also with cerebellar tumors and with cerebellar strokes. So since the cognitive outcomes are really what's the most impactful, I've had an interest in trying to see if we could predict cognitive outcomes. And so with colleagues at Oxford and Zurich, and the first author is here, Andrew Sheridan, we retrospectively looked at a cohort of patients between 2006 and 2013. And this was recently published last year. Of the group of 81, 37 of those patients had sufficient neuropsychological data. And in that group of 37 patients, the mean full-scale IQ was 84, and the median was 90. And this is looking at the last available time point that we had for neuropsych testing. And so that was about 8.5 years old. So these are patients who, are well beyond, on average, 6 to 7 years beyond the acute onset. And you can see that their IQs on average are lower than the mean. This is shown graphically here, focusing here on this column with full-scale IQ. So 54% of the patients had an IQ that fell within the average range. 24% had mildly impaired IQ between 70 and 84, and 22% had an IQ less than 70. So as we see, OMAS can have a significant impact on overall intellectual ability. Unfortunately, we were not able to predict at baseline who was going to turn out to have a better or worse IQ. So we looked at factors that would be available to the clinician at the time of diagnosis, so at 18, 24 months old. So things like age of onset, gender, OMS severity, whether or not they had a neuroblastoma. None of those features were able to predict full-scale IQ. Phrased a different way, I look at that and I say, okay, I really can't risk stratify a patient when I'm seeing them. I can't tell if this patient is going to have a relatively mild course and turn out to do okay, and more likely, are they going to have a more severe course and be at risk for sequelae. So that for me justifies the very aggressive, relatively aggressive treatment that I use up front. As you look at the patient over time, the number of OMS relapses was predictive of full-scale IQ. So the even one relapse impacted it, and so on and so forth. And then also what their OMS severity score was at last follow-up. So this really emphasizes that we want to try to prevent OMS relapses in the first place, with the hope that this might improve cognitive outcomes. This is in line with a couple of other studies that looked at outcomes a little bit differently. This is from an international cohort of patients, pediatric patients with a variety of different neuroimmunologic disorders treated with rituximab, led by Russell Dale in Sydney, Australia. And in the group of patients with OMAS in this study, they were divided at the median time point of initiation of OMAS into the early treated group and the late treated group, which in this study turned out to be 12 months. Although again, in my practice, I'm using rituximab much earlier than that. Nonetheless, if you had OMAS, got rituximab within a year, your modified Rankin score, which is a cruder but easier to apply outcome measure, you had a 93% likelihood of having a good outcome. Whereas if you got it after 12 months, the chances of a good outcome reduced to 63%. And then a third study, which suggests that rituximab may help with long-term cognitive outcomes, was published by my colleague Wendy Mitchell, who's also done quite a lot of work in the field at Children's Hospital of Los Angeles. She looked at an older, more historical group of patients in the red diamonds, none of whom received rituximab, red squares, and compared it to a newer, more modern cohort of patients in whom most of the patients got rituximab, the blue diamonds. And when she looked at the newer group, most of whom got rituximab, their median IQ was 94.5, so almost average. And that was significantly higher than the older cohort. So not definitive proof, but these three studies kind of, to me, coalesce and suggest that rituximab, particularly early rituximab, may improve long-term outcomes. So I've outlined a number of challenges. I've outlined some areas in which we have some data published, and then I've tried to insert also just my personal practical experience. Obviously, we would love to have a stronger evidence base. And so one project that I'm leading at Boston Children's Hospital has been in development of a registry of patients with OMAS. And this is basically a longitudinal observational natural history study. We now have 5 other US sites that are onboarded. It's been a little bit slower and slowed down in part by COVID to get a few European sites onboarded. But we have a number of goals, including to determine the course of illness, prognostic factors, and do some comparative treatment studies. Also to create a registry of what biological material and MRIs are available. And then to establish this as kind of a base potentially for future hypothesis-driven studies and clinical trials. So far to date, we've enrolled 85 patients, so we've made some good progress and hope to continue to enroll and then start to publish using this database soon. So kind of watch this space and look forward to hopefully some enlightening publications from this database. So with that, I'll conclude and just some take-home points. Unfortunately, relapses occur in the majority of patients with OMAS. And if you're seeing a patient with OMAS and they have a relapse, you want to reassess what their baseline treatment is and consider changing it. Unfortunately, also cognitive outcomes are guarded in OMAS. this reflects the more general concept of the cerebellar cognitive affective syndrome, and the cognitive outcomes can be difficult to predict at baseline. All of those things taken together, along with evidence of the involvement of B cells in OMAS, along with extrapolation from other neurologic diseases, and the existing, although limited publications, my approach is to use early multi-agent immune suppression with the goal of reducing relapses and hopefully improving long-term cognitive outcomes. Just a couple of quick acknowledgements. We have an OMS research program at Boston Children's. Previously, my research coordinator was Susanna Camposano, has since retired, and now it's Lauren Kerr, who does a lot of work for this for our program. And then I've received funding from OMS Life Foundation, which is a parent and family-led organization that's quite helpful. I always refer newly diagnosed patients to this foundation. They have a website, they have a Facebook page, and they do have patients from all over the world. So you can certainly refer your patients to this foundation. And then secondly, we've received funding from the Lauren Mance Fund for OMS research from generous donors. So with that, I'll conclude, and thank you very much for your attention, and look forward to your questions.
Thank you, Mark. It was fantastic. Dr. Naveen?
Thank you, Mark. And I think you've already summarized all the important points that you wish the audience to remember. We can, I think, get started with the questions.
Sure. Yeah, Mark, there are actually lots of questions. I'll try to club them together, whichever is like similar sounding, similar looking. So one of the questions is, when you order an MRI, is it a contrast or plain? And would you prefer CT versus MRI when you're ordering this?
Sure. Yeah, that's a great question. So CT is also an option. To be honest, I oftentimes, will kind of talk to / defer to my radiology colleagues in how best to protocol the study. The advantage of, and what the radiologists tell me is that CT scans may have somewhat higher sensitivity for masses in the lung region. So that's one potential advantage, and it's faster. Still, typically, I would say most patients with OMAS would probably still need sedation, but potentially you might be able to get away without sedation. So those are some potential advantage of CT. MRI, I think the clear potential advantage is that there's no radiation. And so taking all that into account, I go with MRI, although CT is also an option. Typically, they do give contrast when they're doing these kind of screening MRIs.
Sure. The next one is high dose DEXA given as a bolus or infusion? So we can start with, is it given orally or intravenously? And I'll add that with another question, that are all the three treatments, dexamethasone, IVIG, and rituximab, started on day one together, or is it given sequentially? So there are two questions over here.
Sure. Yeah, so the dexamethasone, the nice thing about it is it can be given either intravenously or orally. So if the patient is very acute initial hospitalization, they're in the hospital, I may choose to give it intravenously. But it should be equally available, IV and orally. And so that also makes it a nice option for the ongoing use. You don't need to bring them back to the infusion center to give it. In terms of the exact sequence of the three treatments, to be honest, it varies from patient to patient, and some of the factors that come into play. One is whether or not they have a tumor or not. And so if you identify a tumor and you're gearing them up for surgical resection, many times we'll start just with the IVIG, feeling that it won't impede wound healing. It won't increase risk of infection. So give IVIG, get the tumor resected, and then as soon as they're recovered and the surgeon feels comfortable, then start the steroids and the rituximab. If they don't have a tumor, then just kind of start them all at once. I like to give at least some time in between IVIG and rituximab. There's a theoretical reason to think that that if you have a lot of IVIG on board, it might increase the clearance of rituximab. So I'll sometimes stagger the IVIG. I will stagger the IVIG and the rituximab.
Okay, the next one is that most of the autoimmune disorders, including OMAS, have a genetic basis. So does that mean that genetic field may offer a biomarker in the future? Any work going on in this direction?
I love that question because we are looking into that on a couple of fronts. Yeah, as you know, so in terms of take a step back and thinking about genetics of autoimmune diseases, nearly all of the autoimmune diseases are going to be polygenic, usually many genes. There are some of these rare monogenically driven autoimmune inflammatory disorders, but those are quite rare. So we think more likely polygenic. And if you use, for example, multiple sclerosis as a model, which is the genetics have been extensively studied, HLA is by far the strongest risk factor. And then there's hundreds of other genes, each of which contribute a small amount of risk. So OMAS likely follows more of the MS pattern. And because OMAS is much more rare than multiple sclerosis, and because the genetic studies where you have a very small amount of increased risk take, thousands of subjects, it's challenging. Nonetheless, we do agree it's a very important area. And so that's actually one of the study that I mentioned that was funded by Pfizer, where we're starting to look at the genetics of OMAS. So our first level of work was we had observed, and there had been one prior publication on an increased risk of autoimmune disorders in family members of children with OMAS. And so on a very practical level, I always want to ask a detailed family history of autoimmune diseases. For this particular study, we enrolled 35 patients with OMAS and their parents, and we did a detailed questionnaire on autoimmune diseases in the parents and the siblings. And we compared that to data that we had from our pediatric multiple sclerosis network. And then we also had a group of healthy controls. That study was recently published. The first author was my former fellow, Jonathan Santoro, who is now at Children's Hospital of LA. So we showed in that study, it was pretty striking, 40% of the OMAS patients had at least one parent who had an autoimmune disease. That was significantly higher than the pediatric onset multiple sclerosis group, where the figure was 20%, which was higher than the controls, which was around 10%. So very striking family history of autoimmune diseases, which to us suggests that yes, there is a genetic basis. And so we also with that study have done whole genome sequencing in the trios, and the sequencing has been done, and now we're in the phase of kind of validating the sequencing and analyzing. So hopefully we'll find something. Again, it's going to be difficult because it's likely polygenic, and because the numbers are small, it may be hard to tease out these low impact genes. But hopefully over time, if we get enough enrollment in cohorts and sequencing, we can identify specific genes, which may offer, another avenue for understanding the disease.
Okay. Another one that this has been asked by a couple of attendees, that what is the role of whole body PET CT for paraneoplastic etiologies?
Yeah. So I'll answer it in relation to OMAS first. So PET CT, widely used in adult practice to look for neoplasms. As in terms of looking at autoimmune encephalitis or question paraneoplastic encephalitis, your pretest probability is going to be much higher in an adult than a child. And that's been most clearly shown with anti-NMDA receptor encephalitis, where the risk of having a teratoma overall is about 40%, but is very strongly correlated with age. So then you also think about what are the tumor types, and are those particular tumor types PET avid or not? And so, long way of saying, we have not used PET CT in the context of OMAS. Could it add, is there any increased detection rate if you were to do PET CT compared to, let's say, CT alone or compared to MRI? I don't know. I'd be very interested if anybody has any cases where CT or MRI was negative, and then a PET CT picked it up, a neuroblastoma. That would be a very important observation. I'm not aware of any, and in talking with my colleagues in radiology and oncology, we've chosen not to do PET CT.
Okay, fair enough. Is there any experience with other B-cell therapies other than rituximab, like ocrelizumab or ofatumumab, any of these?
Yeah, it's a great question. The sort of variations on rituximab and being sort of more humanized monoclonal antibodies. So to my knowledge, ocrelizumab has not been used in OMAS. I've not used it. I'm not aware of any publications. Ofatumumab, there is one publication from Dr. Pranzatelli where he used ofatumumab in a patient who had anaphylactic reactions to rituximab. And because ofatumumab is humanized, it's much less likely to induce an allergic reaction. So there is that one publication. I think the reason why we've, as a field, have kind of stuck with rituximab is because there's simply way more publications using rituximab in this age group, not just for OMAS, but for other neuroimmunologic disorders, and then for rheumatologic disorders, et cetera. So yeah, I don't know whether ocrelizumab or ofatumumab will end up, supplanting rituximab or not. It's a good question. Certainly in multiple sclerosis in the United States now, so often we are shifting a bit from using rituximab to ocrelizumab.
Okay, the next one has been partially answered, or I think completely covered in your talk, but still for reinforcement, this question has been posed a couple of times over here. So for a child with OMAS, all the three therapies have been given, let's presume dexamethasone plus monthly IVIG plus rituximab, given for 4 weeks. So you do a repeat B cell count after 3 months, you keep on repeating it, let's say till 6 months, and you give a repeat dose of rituximab after 6 months. How many doses of rituximab like this will you give? Till what dose? Or till what age?
Yeah, that's another $1 million question. How many times do you need to give rituximab? And I think it's a very open question. So I personally don't automatically repeat the rituximab. So my hope is that they can get by with a single course of rituximab and not need repeat courses. That's not always the case, and sometimes I do need to repeat the rituximab. And I think the thing that gives me pause, I know rituximab, I love rituximab, and it's extensively used in other pediatric neuroimmune diseases and used very, very freely in adult neurology. I would recommend reading these papers that are being published now on hypogam. And so I think, you know, that's given me a little bit of pause in just in repeating rituximab without a clear indication, because if they get hypogam, a lot of them will have, you know, lifelong hypogam, and it may not prove to be that impactful, but certainly some of my patients are now on lifelong immunoglobulin replacement, you know, which is not insignificant. You know, it's always, everything's going to be a balancing act. You know, what's the risk of undertreated, you know, or not optimally treated OMAS, you know, versus hypogam, you know, and so each patient's and family is gonna have, you know, a sort of individual risk benefit equation and assessment on that. It's a tough question. It's one that I think about a lot.
Okay, continuing with the same case whom we discussed, the same one. So he has received the complete treatment, dexamethasone, IVIG, rituximab. So what is the B cell repopulation percentage at which will be a red flag for you that, okay, I have to be watchful after this? And do you regularly go for CD19, or have you switched to memory B cells as of now?
Another great question. So I'll give the short answer and then I'll expand. The short answer is I use CD19, and basically, and in the study that we were part of with Russell Dale, basically once they hit 10 total CD19 cells detected, then they're going to clearly start to go up kind of rapidly. If they're less than 10, sometimes it can bounce around and is maybe just noise on the flow cytometry. So like if I see 1 cell, I'm not gonna worry about that. Once they hit 10, they're clearly gonna start to go up. And then that percentage will actually vary just depending on their overall lymphocyte count. I have looked at the publications on using memory B cells and trying to, so therefore be more specific and maybe be able to delay the time to using rituximab, looking at memory B cell counts instead of just total CD19 populations. When I crunch the numbers on those studies, it's literally like 1 memory B cell, where you get, I think somebody put in the percentage in the chat, like the 0.005. It literally turns out to be like 1 or 2 memory B cells. And in talking with my immunologists who know much more about this and who run the flow cytometry labs, they feel like that is such, it's very difficult to distinguish 0 from 1 memory B cells on a flow cytometry panel. So I have checked memory B cells in a number of patients, and I've thought about trying to incorporate it into my routine clinical practice, but we haven't yet, right or wrong. But I think it's a great question, and sort of the overall theme of could we be more personalized, do more personalized medicine, and maybe give less rituximab than we need to. In the studies where it's been used, actually in adult NMO is where it's been used, that memory B cell monitoring has been used the most. And those studies suggest that it allows you to give less rituximab. So instead of doing it every 6 months, you're doing it like every 9 to 12 months, which would be quite helpful in our patients.
Okay, there are a couple of questions by Dr. Naveen over here. So when do you use the SARA scale, SARA?
Yeah, so the SARA scale, it's 8 different items, and then each of the 8 items are scored, and the total score comes out to 40. The higher the number, the more ataxia there is. It was developed in the mid-2000s to try to quantitatively follow ataxia. It has been used in pediatric patients, and it's been validated down to age 4. I try to do it in all of my patients at every visit once they turn 4 years old. It's not always possible because there's some tasks on it that are more complicated. And so depending on their developmental status, level of cooperation, they may not be able to do all of the items. But I try to do it starting at age 4. What I have found is that it forces me to do a really detailed exam, and you'll pick up more subtle ataxia than you would if you hadn't. So for example, there's finger chase is one of the items, and so that will bring up subtle deficits. There's tandem stance, so not just tandem gait, but tandem stance, and that oftentimes will bring out very subtle deficits. So I use it age 4 and above. Truth be told, I don't get to it in every patient and every visit, depending on the nature of the clinic session, but I try.
And your clinical target of treatment, is there any cutoff scores that you use or any markers that you say that, okay, now this is the desirable level that I need on this score, and then I'll say that the patient has done well?
Yeah, I think the goal really is zero symptoms. Certainly 0 Opsoclonus. I think that's a very tangible one. We may tolerate a little bit of behavioral issues, oftentimes also because that can be hard to tease out. Is it OMAS or is it something else? But I think the goal is 0.
And any role of anti-plasma cell therapy for resistant cases?
Yeah, I think I debated putting in like a slide on like what else could we think about using, and anti-plasma cell therapies would be one of them. So like bortezomib, for example, it's a rational treatment thought. The idea that you've maybe the patient's already established long-lived plasma cells that are generating autoantibodies, and it's been used and published on in very rare refractory patients with anti-NMDA receptor encephalitis. To my knowledge, hasn't been used in OMAS. I think age, of course, is giving me some pause in using it, but it's rational to think about. Other agents that have been used in rituximab refractory autoimmune encephalitis, for example, would be tocilizumab, which is an anti-interleukin 6 monoclonal antibody. So that's another one that I've thought about but have not yet used. So yeah, I think if anybody has used any of these, novel agents, those would be very valuable cases to publish. Even if it's effective, or if it seemed to be ineffective, just to increase the literature on these novel agents.
Okay, I'll club a couple of situations which many of the attendees have posted. So let's say there's a situation where you are suspecting, or you suspect neuroblastoma in all the cases of OMAS. So would a Dotatex scan or MIBG upfront be more useful than going through the sequence of CT, MRIs, and all those things? What's your experience with that?
Yeah, that's a good question. Yeah, so kind of going back to that cartoon that I showed, with the paraneoplastic framework where the immune system is attacking the neuroblastoma. That the immune attack on the tumor is a good thing. These tumors tend to be grade 1, small, not metastatic, resected, and you're done. So these tumors tend to be small and not that less metabolically active than neuroblastomas without OMAS. So MIBG can be positive, but in that one study, I didn't include it in my slides, but there's a study that looked at the sensitivity of the various measures, and CT and MRI were the gold standard. Those were 100% sensitive. MIBG was about 80% sensitive. And then urine catecholamines were about 20 to 25% sensitive. So it wouldn't be wrong to get an MIBG. It's just that if the MIBG is negative, I'm going to need to get a CT or an MRI anyway. So I've kind of cut out the MIBG. Now it's true that if you do a CT or an MRI and you find a neuroblastoma, the oncologists are going to want an MIBG for their staging. But if the MRI or CT is negative, I don't think that there's a role for MIBG. Again, if anybody has cases where there's CT, MRI negative, MIBG positive, that would be very important to see how often does that situation come up. I haven't come across it yet.
Okay, the other situation is, let's say CT, MRI, and MIBG, everything is negative. So it's a non-neuroblastoma OMAS. And one strategy is to follow them up with serial scans, let's say every 6 months, as you said. So how far do you go to search for an etiology in the first setting, if it is a non-neuroblastoma OMAS?
Yeah, that's a great question, and as you know, if you look at, there's a huge list of potential causes of OMAS. Oftentimes, like single case reports or small case series. The most common would be infection-related OMAS. Infection-related OMAS is going to be more likely in older children and teenagers. So my search for infection will be a little bit more extensive in those patients. In terms of what infections to look for, it's really going to depend on the epidemiology of your location, what season it is, potential exposures. So in New England, where I practice, we'll look for Lyme disease, Borrelia burgdorferi. That's been one infection that's been reported to cause OMAS. West Nile virus, also mycoplasma. So those are some of the ones that I might look for. In terms of how extensive to look for infections, I think will depend on their age, maybe the initial CSF profile, and then other clinical features. One other entity that I actually always screen for, even though there's only one case report on it, but I just feel like it would potentially change your treatment, is celiac disease. So I do basic just blood screening, not like an endoscopy or anything, but blood screening for celiac disease. And then in terms of how, so you do all your screening, tumor screening, it's negative. You do some other infectious workup, it's negative. And I should say also, at least in the genetic causes that I mentioned, quite rare, but like just to have in your mind, as well as there's something atypical about this case, or think about those. So now, 6 months later, you repeat your scan of choice. There's no clear answer on how often do you, and for how long do you keep doing it. I think once you've done, honestly, the 6 month is probably sufficient, potentially one more at 12 months. And then after that, I think the yield of finding a neuroblastoma with these scans is going to be exceedingly low.
Okay, last two questions and then we wind up. This one is, what cell lines cause neuroblastoma related to OMAS? So this can help in rationalized immunotherapy, if at all.
Oh, so what's the tumors? What's the cell of origin the neuroblastomas.
So what cell line cause neuroblastoma-related OMAS? And I'll just extend it further. So is there any role of onconeuronal antibodies which are performed at times in some of the centers, those anti-Hu and anti-MA and all those things?
Sure. Yeah. So there of the known autoantibodies, anti-HU is the one that's most commonly reported in pediatric OMAS, although the percentage of cases is quite small, probably around 1% or so. So I do send those antibodies on the off chance that maybe somebody will be anti-HU positive. But pretty universally, all the other antibodies, will be negative. We and other groups, have been trying to find the elusive autoantibody in OMAS. There was one paper that was published from the Oxford group that reported finding anti-GLU-D2 antibodies. That was published a few years ago. Seemed quite exciting. It seemed very rational as to why that could be an autoantigen. Unfortunately, the Barcelona group tried to replicate it and couldn't replicate it. So it seems like that's another dead end in the search. So we still don't know what the autoantigen and autoantibody is in OMAS.
Okay, the last one for the day. Any role of plasma exchange?
Yeah, that's a question that comes up a fair amount. I am not a big fan of plasma exchange in the setting of OMAS for a couple of reasons. One, usually, so I kind of make it super practical. You've got like a 2-year-old with new onset OMAS. They're extremely irritable, crying all the time. Now you're going to put in a central line into them and try to do plasma exchange. And from a practical standpoint, I think it's very, very challenging. It's also temporary. You're not going to use plasma exchange as a chronic treatment for them. So I feel like it has a relatively limited role. If there was a patient who, you did your initial treatments and still was like floridly symptomatic, it could be considered. I think I've done it in one patient in my time treating patients with OMAS. Some centers do, particularly Toronto Sick Kids, and Ye has published a little bit on plasma exchange for OMAS. So it's an option. It's just not one that I have tended to use.
Thank you so much, Mark. I think if we leave it open, people will keep on asking questions, but we'll have to stop over here. I'll hand over to Dr. Naveen for his concluding remarks.
Thank you, Mark, for the wonderful talk and really taking on all the questions, really sharing your experience. And on behalf of the Association of Child Neurology, we really thank you for your valuable time and all the attendees for such an interactive session. So thank you, Mark, and thank you everyone who joined in. Dr. Anaita and Dr. Kavita, if you have to say anything.
Nothing. Excellent talk and excellent session. Thank you very much, Dr. Gorman. And Dr. Vishal had asked how we can contribute to your registry that you are developing. If you can give the last remarks on that. Thank you very much.
Absolutely. Thank you for asking that. We are interested in expanding the registry. We want to get our stuff in perfect, like very good order first before we roll it out. But yeah, let's definitely stay in touch because we are interested in expanding it. So yeah, I'm hopeful that as we sort of streamline our processes and move things along, that we can include you guys as well.
Thank you very much.
Thanks again for the invitation. I really enjoyed the session. Excellent questions. It was fun.
Thank you, Mark. Thank you very much. Right, so we'll just close the session, sir.
Yes.
Are we not announcing the next session, Dr. Vishal?